When I studied at the university, I took a class like this that started with many people in the class. Too many people, not enough chairs. And the professor said, by the end of the class, we will hold it in the closet. So we're almost to the closet size now. But I appreciate your being with us as we will talk about adenocarcinoma of the cervix today. This has precursor lesions that have been called adenocarcinoma in situ, usually presenting about 10 years ahead of invasion. So cytology is an important prevention for adenocarcinoma, as it is for squamous carcinoma of the cervix. This is an HPV-related lesion, a disease, and very commonly HPV-18. There are several subtypes which we will illustrate. So as we find P16 staining useful in squamous lesions, it's also very useful in glandular lesions. There is an important difference in that there are some benign lesions which can have P16 staining in glands. So some endometrial glands may stain positively. Some tubal metaplasias may stain positively. But the pattern of staining will be different than carcinoma in situ. Adenocarcinoma is also usually PAX8 positive, but PAX2 negative, which is different from normal endocervical epithelium. So these markers can be useful to differentiate normal reactive from neoplastic endocervical epithelium if you have them available. In our laboratory, we do not use this a lot, but we do have both markers. PAX8 is the more commonly used one. Here is a nice example showing at the top, up here, normal endocervical mucosa, and here you see slightly darker, more complex glands associated with adenocarcinoma in situ. The contours of the glands are still fairly similar to the normal glands. Higher magnification. Yeah, it's not working. Higher magnification, you see that, there we go. Okay, there we go. That there is some stratification and darkening of the nucleus. We lose the cytoplasmic mucin, and the architecture gets more complex. Oops. The nuclei become crowded. Chromatin is more coarse. There are mitotic figures, and also usually karyorectic debris, blue debris from the nucleus. These are very useful findings to help with this diagnosis. Here's a more elongated gland with villus pattern architecture that also can be seen with this disorder. Here we see this karyorectic debris. The nuclei often are still at the base, but they're very dark, and some mitotic figures are useful features. High magnification, crowding of the nuclei, debris, and some mitotic figures. Here are two apoptotic bodies over here. So here is the appearance with P16. As you see, it stains the nucleus and some of the cytoplasm. It doesn't stain the mucus. So you could still have clear areas in the cells, but if there is no mucus in the cell, they will stain positively. And the benign glands, endocervical glands, no staining. So very clear cut marking. Now, what can this be confused with? Well, some authors identify a category of endocervical glandular dysplasia. Very hard distinction to make. We'll talk a little bit about that. Early invasive cancer could be seen. And then secondary tumors, an implant from the ovarian or uterine site, or extension of endometrioid cancer down into the endocervix. Usually these benign processes are not an issue. These lesions are managed with usually local excision and close examination of the margins. Many patients will now be followed with follow-up HPV testing to determine if there is any residual HPV. This is highly predictive of recurrence or residual disease. And of course, looking for evidence of other HPV-related diseases is valuable. So, as in the squamous mucosa, we recognize the precursor lesions, low grade to high grade. And so we'd like there to be a similar progression for glandular lesions. And so we want there to be some sort of precursor lesion. It makes sense to us. The problem is that recognizing it and classifying it and distinguishing it is hard. So those who have written about this say, well, it's like AIS, only lesser amounts, lesser features, not as fully developed. And that becomes very difficult to reproduce between me and you. If I say, if you have nuclear hyperchromasia but no mitoses, or you have one mitosis, or it can be very subjective. And in terms of treatment, mostly it's going to be managed like adenocarcinoma in situ. So the management will be the same. So essentially we have a two-tier system like we do for squamous lesions, normal, no follow-up, and AIS and anything leading up to that, which should be excised. So I think we will probably stick with just two categories in this side of things. So invasive endocervical adenocarcinoma can fit into the early invasive, so-called micro-invasive category, usually less than 5 millimeters in total thickness, not just 5 millimeters of invasion, total thickness, and less than 7 millimeters in width. Some people also will define an area less than 500 cubic millimeters. These patients can do very well with just local excision. This is an example. Here are the normal endocervical, or the in situ endocervical glands. Here's an area of early invasion. Here's some more examples. Here is the normal depth of the endocervical glands, and these are just slightly deeper. Early focus here, or in very early gland over here. How do you measure? The same way we measure the squamous lesions. But it's harder because deciding where the nearest normal gland is very hard or impossible with this. So most of the time I will measure from, say, here to here type of process. But I think that's also the reason why in this criteria a total mass, depth, width, thickness may be the most useful metric and most reproducible, to use tumor size overall, top to bottom, width as your measurement. EC is endocervix. Endocervix. Endocervical. Yeah. So invasive, fully invasive adenocarcinoma will usually form somewhat of a mass and is more evident clinically. These earlier lesions, adenocarcinoma in situ, early invasion, may not be visible colposcopically. So they may have to just do a blind cone biopsy to try to excise those. This is usually somewhat visible. What's happening with this tumor is that this is increasing in incidence. So, whereas previously it was maybe 10%, now it's higher. And that may be because detection for squamous lesions has improved, but the incidence is changing for endocervical lesions. We don't know why for sure this is occurring. These are usually associated with some sort of symptom or mass, though there are some presentations which may be atypical. For example, an ovarian mass, a MET, may be the presenting symptom, or there may be hypercoagulable state like Trousseau's syndrome. The prognosis depends upon the subtype, the depth of invasion, status of the margins, and especially whether or not there is lymphovascular invasion and so forth. We don't think that there's a very good association between grade and prognosis. So don't spend a lot of time on that. However, the pattern of invasion is important and predictive of lymph node metastasis. So you'll see the term destructive invasion. It's destroying tumor, destroying tissue. That is a good indication for a sentinel lymph node biopsy. Whereas a well-demarcated tumor, sharply circumscribed, not destructive, not necrotic, doesn't need a lymph node dissection. Or vascular space invasion in more than 3 foci, these will benefit from lymph node dissection. So this is the usual type. I could show you this for adenocarcinoma in situ. It looks the same. The only difference is where it is and what it is doing. This also could be adenocarcinoma in situ, but if it's forming a mass or infiltrating, it is obviously invasive. This is the usual type of endocervical adenocarcinoma. It has a slightly paler cytoplasm, a little bit of mucin remains, and it's a neutral mucin that you would expect in the cervix. P16 will also be positive in invasive tumors and can be useful sometimes in finding small areas of occult invasion or lymphatic spread or something like that. Usual type doesn't usually form this villus architecture. And this is important because there is a villoglandular type of endocervical adenocarcinoma that is less aggressive. It's more benign, if you will, and has a very pronounced villous pattern. Here's another pattern of a microcystic pattern. This could easily be mistaken for tunnel complexes or something like that. So looking for the cytology in an area gland like this or this can be very helpful, because many times these cells out here will be compressed, but the nuclei will still be atypical. Here again, it's microcystic pattern. Very subtle atypia to some of these glands here. Yeah, this can be challenging within large glands. Yeah. Yes?
We have to base on some glands here.
Yes, you have to look for this sort of change or these changes here, and maybe some glands like this to help you. So we'll talk about distinguishing endocervical from endometrial. P16 is sometimes used, but it's not totally helpful because many endometrial cancers may also be P16 positive. So in that differentiation, it's not as helpful as other markers that we'll talk about. But we'll get to that question of the immunohistochemistry. Here's a sort of microcystic pattern as well that can be seen. So the differential for this usual type is viloglandular endocervical adenotype, endometrial adenocarcinoma with extension. And here is the profile. So P16 can be useful, CEA and estrogen receptor negative. This favors endocervix, whereas endometrial usually will be positive for the hormone markers and Vimentin, and negative for CEA, and negative for P16. But the P16 can be a little bit variable. And then there is also an endometrioid type of endocervical adenocarcinoma that would also have this profile. So let's talk a little bit about the viloglandular type of adenocarcinoma, which is not a common subtype, but it does occur. And these are usually younger patients who have used oral contraceptives. And it has this very striking villous pattern. Low nuclear grade, so all grade 1 nuclei. We don't usually make this diagnosis on just a biopsy, although we will suggest it if we see this pattern, that it could be this type. But we usually like to see an excisional specimen to make the firm diagnosis. And this is a good prognosis lesion because it has usually very minimal invasion and is very circumscribed in terms of margins. So here's an example of what this looks like. Very villous pattern, low nuclear grade. Sort of looks like a villous adenoma of the colon in terms of the elongate projections and pencil-like nuclei. There is a mucinous, or sometimes called gastric type, adenocarcinoma that's sort of a more intestinal type of histology. It has some intestinal mucins, and it may occasionally express intestinal markers like CK20 and CDX2. These patients usually do not do very well. So here's an example. You see the mucus here, higher grade nuclei, could be difficult to distinguish. So sometimes doing the markers to clarify the type, so looking for any of these intestinal mucins or CK20 and so forth could be useful. And here's a more, if you see the goblet cells, well, that's usually a little bit more characteristic and helpful. You don't have problems with it in that case. Now, this is a very challenging case. I still remember the first time I saw one of these lesions, and we looked at the slide and we thought, oh, those are just misplaced glands. They looked very, very benign. But they were very deeply located in the cervix. So these are very bland nuclei, but it tends to invade very deeply. Usually there's one or two areas where you have dysplastic nuclei, mitoses, and so forth, but there's no stromal reaction or very minimal, and these patients tend to progress and do poorly. So here's an example, very well-defined glands, minimal atypia. We'll show some higher magnification. Here you see how basal these nuclei may be, and this you could say just a hypermucinous gland, okay? Yeah, it looks benign. So the clues are finding other glands associated with them that are more dysplastic, and the location. These are not superficial. So if you find a proliferation like this very deep in the cervix, you should be thinking adenoma malignum, not displaced glands. So this is, location-wise, will be very deep in this tissue. For example, here, see down in the fibromuscular stroma, cells that just, glands don't, they're too deep for where they belong. They're not common, fortunately, but they do occur. So there's very subtle hyperchromasia, and we might find an occasional mitotic figure. And notice where it is relative to this vessel. So it's very close to a big vessel that would not be where a normal gland should live.